Welcome back. Let's walk through a real world scenario that ties it all together. This scenario is adapted from a composite of typical cases. Dispatch gives you an 85-year-old female at a nursing home with altered mental status. Upon arrival, the nurse informs you the patient has a history of dementia, but is usually pleasantly confused and calm, maybe a bit forgetful but cooperative. She recently had a hip replacement surgery and had been on opioid pain meds. Over the last day, her behavior changed dramatically. She became agitated, not eating, and refusing care. Red flag, an acute change. You find the patient in bed, indeed very agitated, moaning loudly, and her nasal cannula is lying on the bed next to her. She seems kind of out of it, perhaps even in pain. When you approach, she starts screaming at you, telling you to get away and accusing you of harm. She's clearly afraid and combative. She can't answer who she is or where we are. Classic disorientation. Instead, she just keeps shouting that she's in pain and pushing you away. This can be a dangerous situation. She's not only suffering, but could also hurt herself, maybe fall out of bed, or hurt providers. You quickly get vitals and an exam. She is tachycardic, hypotensive, and febrile. Those vital signs scream sepsis, infection in the bloodstream leading to shock. You find evidence of a probable infection. Her surgical wound looks infected, red, oozing, and she might have a bit of raunchy. Maybe she aspirated or is developing pneumonia as well. Blood sugar is normal, so hypoglycemia is not the cause. No stroke signs like one-sided weakness. So, the picture fits delirium due to sepsis in a patient who also has underlying dementia. So, how to manage? First, address ABCs. She's oxygenating okay, but not great. So, you want that nasal cannula back on. She initially ripped it off, but after you speak gently and maybe have a familiar nurse help, you get it back in place. Next, address pain. She had surgery, and she's saying she's in pain. Untreated pain can intensify delirium, plus it's just humane to treat it. You carefully give a small dose of an opioid, small because she's old and hypotensive, but enough to take the edge off, or if you are an EMT or AEMT that is not working with a paramedic, see if you can better position the patient where she experiences less pain. And indeed, as her pain eases, she's slightly less vocally distressed. But she's still quite agitated and paranoid. She was fighting your partner when they tried to take a blood pressure, for example. Given her age and sepsis, you, if the paramedic, may choose to use haloperidol or ketamine rather than a benzo to safely calm her. Following protocol medical direction, you administer a dose IM. If not, make all attempts to verbally de-escalate and keep the patient calm. Within minutes, the medication or verbal de-escalation helps. She transitions from yelling and physically resisting to a state of being confused but more tranquil. Now she's maybe just softly mumbling or crying but not trying to hit or pull away. This is a good outcome because it allows you to do necessary treatments. You establish an IV if able, begin fluids for her low BP, she likely needs IV fluids for sepsis, and you can keep her on the stretcher safely. During all this, you and your team are constantly communicating calmly with her. Even when she was screaming, you didn't yell back. You kept a soothing tone. Ma'am, I know it hurts. I'm sorry. We're helping you. It's okay. You validated her pain and fear while moving forward with care. You also had the presence of mind to suspect sepsis given the vitals and context, so you call ahead to the ED. We have an 85-year-old female, history of dementia, now with acute mental status change. Likely septic from a hip wound infection, vitals are. We've given fentanyl and haloperidol or ketamine to manage pain and agitation. Starting fluids will need sepsis workup on arrival. This heads up lets the hospital prepare for a potentially critical patient. Transport is done without sirens because although she's sick, you're already doing the key interventions, oxygen, fluids, etc. And running code might only agitate her more without significantly changing arrival time. You focus on monitoring her, ensuring her airway stays open. She's calmer, but watch that her sedation isn't too deep. You keep talking to her occasionally. You're doing fine. We're almost there. She might still be delirious on arrival, likely will be until antibiotics and further care are given in hospital, but at least now she is safely delivered to where she needs to be. This scenario highlights delirium superimposed on dementia. She had baseline dementia, but something new, infection, pain, meds, caused acute delirium. The EMS team recognized it and treated both her symptoms, pain, agitation, and began addressing the cause, oxygen, fluids for sepsis, calling ahead for definitive care. By doing so, they probably prevented further harm. Imagine if she hadn't been treated. She could have gotten worse and maybe become unresponsive or gone into septic shock unnoticed. In this second scenario, we see a different kind of call, one that's not uncommon. An elderly dementia patient who has wandered from home. Such patients might be reported as missing or found by bystanders or police in an unsafe situation, like trying to cross a highway. Here, Dispatch involves police already on scene with an older gentleman found in traffic. When we arrive, the police have done a great job protecting him. He's in the cruiser staying warm. We immediately note he has a medic alert bracelet indicating Alzheimer's, a big clue this is a dementia case. There's contact info for a daughter, which is a gold mine for us to help get him home. The patient, John, is quite confused about where he is and what time it is. He keeps saying he needs to go home and maybe thinks he's late for work from decades ago. This is classic Alzheimer's behavior, often reverting to old memories, lost in time. Importantly, aside from being confused, he's physically okay. No injuries except a little scrape, vitals all normal, no signs of acute illness or trauma. So our medical assessment leans towards he's not delirious, he's at his baseline dementia. The fact that he's relatively calm, just lost, and has a known Alzheimer's diagnosis points to chronic issue, not an acute medical emergency. Our job here is largely about safety and compassion. We need to ensure he indeed has no injuries or urgent medical needs, and then get him to appropriate care, which might simply be back home with his family if that's safe, or to a hospital if we had any concerns. We use all those communication skills. Approach him slowly, at eye level, with a friendly greeting. He's anxious, so we reassure him. You're safe. We're here to help. We don't belittle him or say, "Why did you wander off?" Obviously, he doesn't fully know. We also don't argue when he says incorrect things. When he says, "I have to get home now, I'm late for work," we empathize and redirect. "I understand you want to get home. We'll make sure everything's all right. How about we step into my ambulance where it's warmer while we figure this out?" This way, we avoid directly saying, "You don't work anymore," or "You are home, you just don't know it." That would confuse or upset him more. Instead, we address the feeling, he's anxious about needing to be somewhere, with a general reassurance and then guide him to a safe next step, sitting in ambulance. Notice he initially didn't want to get out of the police car because he thought he's waiting for a ride. Instead of forcing him, we coax with a reason he can accept. It's cold, come warm up. This kind of therapeutic fib or gentle coaxing is often needed. We also ensure he's physically okay. Check that scrape, clean it, maybe put a bandage. That's minor, but it's part of our care. Meanwhile, the police contacted his daughter using the bracelet info. If we were alone, we'd do that, but PD often assists in such cases. The daughter arrives and we confirm she can take over care. We have to assess, does this patient actually need to go to the ER? In this scenario, no acute injury or illness, he's just lost. Once family is here, it might be appropriate to release him to them with advice. However, EMS protocols vary. Some would still require an ED eval to be safe. But let's say in this case, with thorough assessment and family agreement, we do a non-transport with proper documentation. We also did a kind thing, gave some advice about preventing future incidents, which caregivers often appreciate, and some EMS systems have community resource info for this. Not strictly required, but it shows holistic care. And this scenario shows an encounter that's less about treating a medical condition and more about using scene management and empathy to resolve a potentially dangerous situation for a vulnerable person. There was no IV start, no medications given, but our presence was still very important to ensure the patient was fine and to lend assistance to the police and family. Key points from this scenario identify that it's likely a dementia wanderer, confirm no delirium, no infection signs, vitals stable, just baseline confusion. Keep the patient calm and safe, involve law enforcement and family appropriately, and ensure a warm handoff either to family or to hospital. We covered a lot: definitions, brain science, assessment, communication, management, and scenarios. With this knowledge and approach, you'll be better equipped to handle calls involving cognitive disorders. Delirium and dementia each present unique challenges, but as EMS professionals, our blend of medical skills and people skills can make a huge difference in these patients' outcomes and experiences. Thank you for your attention. Stay safe out there, and remember that calm, informed care is the key when dealing with altered mental status in the field.